Hello, everyone. Welcome again to our grand rounds. I have the pleasure of introducing Dr. Shu-Ching who got his Ph.D. in neuroscience at Johns Hopkins and his M.D. prior to that at the National Taiwan University School of Medicine in Taipei, in Taiwan. He is currently assistant professor in the Department of Neurology here at the University of Washington. He had a fellowship in movement disorders for 2 years in the Department of Neurology at Columbia University in New York. And he had his residency prior to that in the Department of Neurology with us at the University of Washington. He's a member of the Movement Disorder Society, a member of the Huntington's Disease Study Group, and a diplomate of the American Board of Psychiatry and Neurology. In his career, he's had 11 publications focusing on movement disorders and 4 research grants, some of them which are current. And the research grants are in the study of various aspects of the study of movement disorders. He's going to speak to us today on the diagnosis and treatment of Tardive syndrome. So, Dr. Hu, thank you so much.
Okay, yeah. Thanks a lot for the very, very kind words. And I always feel very, very nervous, but also very, very adventurous when talking to the psychiatrist about Tardive syndrome, a condition that probably psychiatrists see more than neurologists do. So today, I will talk about diagnosis and treatment of Tardive syndrome, strictly from a neurologist's perspective, and show videos of some of my patients with Tardive syndrome. And all the videos were obtained with consent for educational purposes. So this patient was on Haldol and Prolixin for bipolar disorder. And years later, she developed several types of movement disorder. The first type is mouth movements. So just very, very stereotyped, repetitive mouth movements. I think most people here, we're seeing this on a daily basis. So this is what we call Tardive dyskinesia. So in addition to the mouth movements, she also had spasms of her neck and back. So these movements look very, very different from the mouth movements. And they're very, very forceful, kind of posturing type movements. And mostly when she was walking. Okay, so this type of movement is what we call Tardive dystonia, so different from Tardive dyskinesia. And then in addition to those 2 types of movements, she also looked restless, and she also felt restless. So it's just very, very fidgety. But the movements, the body fidget movements are not very stereotyped. So different from the Tardive dyskinesia, and also different from Tardive dystonia.
Does she have any insurance here? Yes, Medicare and Medicaid.
Okay, so the third type of movement is what we call Tardive akathisia. And later I will show you more videos about these individual types of Tardive syndrome. So Tardive syndrome is just a part of drug-induced movement disorders. So there are lots of medications that can cause movement disorders. And but those caused by antidopaminergic medications, I think accounts for the majority of drug-induced movement disorders. And for lack of better term, we still call the movements caused by antidopaminergic medication EPS, extrapyramidal syndrome. So the EPS is divided into several types, and the onset can be very, very acute just after very short exposure, and that's called acute or subacute EPS. And they include dystonia, akathisia, or the most severe one, the neuroleptic malignant syndrome. So these are acute EPS. And EPS can happen probably in a delayed fashion. And that's the topic of today's talk, Tardive syndrome. So both acute or subacute EPS and delayed EPS are considered idiosyncratic, though you cannot predict who is going to develop that or when the problem will surface. So that's different from the third type of EPS, that's drug-induced, that's Parkinsonism. In drug-induced Parkinsonism is dose-dependent. And if the dose is high enough, everyone will develop Parkinsonism. So it's very different from the acute and the delayed EPS. So for today's talk, I will just focus on the delayed EPS. So that's Tardive syndrome. So what does the delayed mean? So people can develop Tardive syndrome when they are still on antidopaminergics or when they are off antidopaminergics. So the definition for sort of Tardive or delay is that it's probably required at least 1 month of exposure. I think before the cutoff was thought to be 3 months, but now we know that for some people they can develop Tardive syndrome with no exposure as short as 1 month. And the Tardive syndrome can also happen after the medication, antidopaminergic medications have been discontinued. And in this case, and the movements surface usually within 6 months, and occasionally the movements, Tardive syndrome, surface between 6 to 12 months after discontinuing medications. And Tardive syndrome never occurs 12 months after neuroleptics or antidopaminergics are discontinued. If a movement appears 12 months or a year after a medication is discontinued, it's not Tardive syndrome. We're dealing with separate movement disorders. So as I mentioned earlier, Tardive syndrome is considered idiosyncratic, and so there's no way to predict who is going to develop that. And there's no safe threshold, so it's hard to predict. But we know that the risk of developing Tardive syndrome increases as the duration of the drug use goes up. And the prevalence of Tardive syndrome, I think, is very difficult to estimate. Depending on different studies, I think the prevalence is estimated to be between 5 to 20%. So in addition to duration of exposure, there are other risk factors. So probably most people here know that typical neuroleptics are carrying much higher risk than atypical neuroleptics in causing Tardive syndrome. And also gender and age also matter here. For example, older women tend to develop Tardive dyskinesia, kind of the mouth movement type of movement syndrome. But younger men actually tend to develop Tardive dystonia. So the biology behind that is still not very clear. And the other thing is about sort of the way these medications are used. I think in the old days, I think people used to do sort of drug holidays, put patients on antidopaminergic for a while and then stop the medications, try to prevent Tardive syndrome. But later we learned that actually by doing this, interruptions or drug holidays actually it increases the risk of Tardive syndrome. So the natural history of Tardive syndrome is non-progressive, but usually the severity plateaus after several months. And it's still possible to have spontaneous remission, but again, it's almost impossible to predict who is going to have spontaneous remission after Tardive syndrome occurs. Okay, so just a very, very brief review of the antidopaminergic drugs. So antidopaminergics are kind of broadly divided into two categories. The first category is dopamine depleters that work presynaptically. So there's several, like reserpine or like tetrabenazine or metyrosine. So their pharmacologies are no different. So reserpine block the vesicular monoamine transporter, so type 1 and type 2. So type 1 is peripheral, type 2 is central. And the other similar medication is tetrabenazine. So it's different from reserpine. It only blocks the type 1, the type 2 transporter. So it has no peripheral side effect. I think type 2 is only expressed centrally. And there's another medication that probably, I think, no longer in use is metyrosine. So that's a medication that inhibits tyrosine hydroxylase. So these medications are dopamine depleters that work presynaptically. So the other category of antidopaminergic medication is dopamine receptor blockers that work postsynaptically. And this category includes typical neuroleptics, atypical neuroleptics, and also medication for nausea and vomiting, Antiemetics. So it's important to remember that. So both dopamine depleters and the dopamine receptor blockers can cause acute or subacute EPS and Parkinsonism, but only dopamine receptor blockers can cause Tardive syndrome. So there's a difference between these two categories of medications. So the history of Tardive syndrome unfortunately echoes the history of developments of antipsychotics. So the first antipsychotic that is antidopaminergic is reserpine. But reserpine is dopamine depleter, so it does not cause Tardive syndrome, although it can cause other type of EPS. So the first antidopaminergic the first antipsychotic that is a dopamine receptor blocker is chlorpromazine. So it was introduced in 1952. And in 5 years, the first case report of Tardive syndrome was published. And the term Tardive dyskinesia, I think, was coined several years after that. And to try to prevent this problem, so there's so-called atypical neuroleptics were later introduced. The first one, as everybody here knows, is clozapine. But it has other side effects. The most serious is agranulocytosis. That's why I think other atypical neuroleptics were subsequently introduced. And now I think there's still more to come, to this day. So what's the difference between typical versus atypical neuroleptics? So I'm not going to into details here. I think probably most people here know probably better than I do. So the risk of causing Tardive syndrome is directly associated with the binding affinity to the D2 receptor that is expressed in the striatum. So in this table here, so there are numbers for the binding affinity. The higher the number is, the lower the binding affinity is. So for example, for Haldo, the number is very, very low for the D2. So that means the binding affinity for the D2 receptor is very, very high. That's why it's a typical neuroleptics. And if you look at clozapine, so the binding affinity is very, very, very low. So in terms of atypicalness, clozapine is a true atypical neuroleptics. And for quetiapine, the binding affinity is also relatively low, so it can pass as an atypical neuroleptic. But if you look at the D2 binding affinities for other neuroleptics, like Zyprexa, risperidone, or geodone, even they are labeled as atypical neuroleptics. But if you look at the binding affinity, actually the binding affinities are quite high, although not as high as Haldol. So in my opinion, there are only two atypical neuroleptics. The first one is clozapine. The second one is quetiapine. I think for Zyprexa, I think probably is somewhere between typical and atypical neuroleptics. And how about other newer generations of atypical neuroleptics like Abilify or like Buspar? And for Abilify, the binding affinity actually is very, very close to risperidone. But the problem is Abilify is a partial agonist. So even the binding affinity is close to risperidone, it's still hard to interpret its relative risk compared to risperidone, because risperidone is a pure antagonist. And that also applied to Buspar, is a partial agonist. So even the binding affinity is high, we don't really know the risk of causing Tardive syndrome is that high. But as these two newer generations of atypical neuroleptics are used more common, I'm seeing more and more patients actually with EPS, including Tardive, caused by Abilify and caused by Buspar. So just remember that not all the atypical neuroleptics are the same. Some are truly atypical, some are not truly atypical in terms of the risk of Tardive dyskinesia. So in addition to neuroleptics, and we also see patients with Tardive syndrome caused by the other group of antidopaminergic medication, that's medication for nausea and vomiting, Antiemetics. And some of them actually just work centrally, like compensing or Reglan. They work centrally in the central nervous system, so they can cause Tardive syndromes. But there are other antiemetics that only work peripherally. They don't penetrate blood-brain barrier, so they don't usually cause Tardive syndrome if you use a regular doses, such as Tigan or domperidone. But these peripherally acting or safer antiemetics, they're kind of hard to get. Like, for example, domperidone is only available in Canada. It's not available yet in the U.S. And Tigan is still available, but not every pharmacy carries that. But anyway, they're safer alternative if you're thinking about using medication for nausea. So if you can find Tigan, usually that would be my recommendation, to use Tigan instead of using compensing or Reglan. Okay, so probably enough pharmacology for everyone here. So so to make things more complicated, that's what we neurologists do. So we divide Tardive syndrome into several types. So earlier, I think for the first video that I show you, I think I talked about the Tardive dyskinesia, and Tardive dystonia, and Tardive akathisia. Those are three most common types of Tardive syndrome we're seeing. And in addition to these three types, there are other types of Tardive syndrome which are not very, very common. For example, Tardive chorea, and is mostly seen in children when their neuroleptics are stopped very, very fast. They can develop very, very florid chorea. That's what we call withdrawal emergent syndrome. I think we're seeing maybe like 1 to 2 cases probably each year. I think at Children's Hospital, the withdrawal emergent syndrome. And also there's a condition called Tardive pain syndrome, and some people believe is a focal form of akathisia. And also there are other movement disorders that have been called Tardive, like myoclonus tremor, tics, or Parkinsonism. But we're not entirely certain they're really Tardive syndrome or not. So, so I'm going to focus just on the first three major types of Tardive syndrome. So the first type is what we call classic Tardive dyskinesia. So, so the name is not perfect. So some people call that Tardive stereotyping. So the movements are repetitive, stereotyped, and sometimes the movements are rhythmic. So look very, very different from as Korea. Look more similar to the movements stereotypy that we see in people with autism. So very, very repetitive movements. And the movements usually involve the face, mouth, or tongue, and we call that OBLD, orobuccolingual dyskinesia. It just affects the tongue. I think some people call that flycatcher's tongue. And in the limbs, the distribution is more distal than proximal, and some people call that piano playing fingers. And sometimes this type of Tardive dyskinesia can also affect breathing, also create abnormal vocalizations. And the classic Tardive dyskinesia is suppressible. So when the patients are aware of what they're doing and they can stop this type of movements. And typically, Tardive dyskinesia does not interfere with physical function. So, so this patient developed movements of mouth, trunk, and also involuntary vocalization after taking a number of neuroleptics for bipolar disorders.
Okay, I'm doing well.
How's your mood?
I'm moving good. Moving good.
When was the last time you felt depressed?
That's when I felt depressed.
So very stereotyped, repetitive, and rhythmic movements.
I've been pretty upbeat, and it's caused me to think more clearly.
Also some vocalization.
And I've actually, like I said, I haven't had driver's license in 27 years, and I went through the process and everything, because I owed a ticket from 27 years ago.
Yeah, so for the mouth movements, so obviously, they cause vocalization, but whenever she was talking, there were no mouth movements, and the vocalization, stopped. So this patient develops abnormal tongue movements that he called tremors after taking just Reglan for nausea.
Mr. Hopkins, how long have you noticed your tremor and your mouth movement?
About a year.
So again, whenever he was talking, the movement stopped.
And you've been taking Reglan on and off for about 3 years.
Yeah.
How about your mouth movement and your tongue movement?
Well,
What does it bother you?
quite a bit when I, especially when I'm out public, at home, sitting watching TV or whatever. I just find myself doing it all the time.
So does that bother you, or you feel bad?
Bothers me.
And those movements around your mouth, do they interfere with your speech, chewing, swallowing?
Not so much.
Okay,
So
so
they're there, and feel bad about it. But they don't really cause any physical trouble.
No, I don't think so.
yeah, so
How much do you have control over those movements around your mouth?
When I think about it, I have control, but when I'm not thinking about it, it just takes off on its own.
Oh, okay. Stay open.
so now he was aware,
Stick your tongue out.
so he didn't really have too much movements. Yeah.
And the $20 is only $15.
So that's sort of hallmark of Tardive dyskinesia or Tardive stereotypy, and it's suppressible. It doesn't cause functional interference. So talking, chewing, swallowing, they're not affected. So they're different from Tardive dystonia, which I'm going to talk about later. Okay, so this is a very unusual type of tardive dyskinesia, and also sort of repetitive and stereotyped. So she took compensing for years for migraine, and unfortunately, she later developed involuntary movements. To look at her belly, yeah. So some people call that belly dancers dyskinesia, yeah. So kind of very slow, movements. So also movements of the gluteal muscles. Probably it's hard to see from here. Yeah. It's probably easier to see from these angles. So now you see the movements. Yeah. Another one here. So again, repetitive, stereotyped. So she's a grade school teacher, so she has to stand in front of a class and the students a lot. So you can imagine how embarrassing these movements are to her. So these are examples of classic tardive dyskinesia. The second major type of tardive syndrome is what we call tardive dystonia. And if that affects the extremity, the distribution is very different. The distribution is more proximal than distal. It can affect the sort of the mouth area, and we call that oral mandibular dystonia, or OMD. And different from tardive dyskinesia, and tardive dystonia just likes to affect the trunk, the torso, and typically you see a combination of neck extension, that's what we call retrocaudus, and also trunk extension, opisthotons, and internal rotation of the shoulders and extension of the elbows. So if you see these combinations, extension of the neck, extension of the trunk, also internal rotation of the shoulders, pretty much, you can guarantee that you're seeing tardive dystonia, but not other type of dystonia. And as a matter of fact, tardive dystonia is the most common cause of secondary dystonia in adult populations. But in terms of phenomenology, there's no way you can tell it is a tardive dystonia or this is dystonia caused by other things. So we saw this video already. So. And just look, so again, extension of the neck, extension of the trunk, also internal rotation of the shoulder and extension of the elbows. So this is typical tardive dystonia. Okay, so the truncal dystonia caused by neuroleptic exposure. So this patient had open heart surgery and was delirious and was given Haldol, just probably for several weeks, and then later developed blepharospasm, excessive eye blinking.
So this is what it would be if you weren't working to stop that. So pretty bad.
Okay, so this is another sort of flavor of tardive dystonia. In addition to, besides trunk, it can also affect the eye blinking muscles. And the tardive dystonia can also affect extremities, and that can look like writer's cramp. So you see sort of tremulous movements that's position dependent. So that's a hallmark of what we call dystonic tremor. So not regular essential tremor or Parkinsonian tremor. These tremulous movements are dystonic tremors.
So that is the worst posture. Is that right?
So again, on both sides. So now in walking, you can see more kind of obvious posturing movements of the hands.
Okay, come on back now. Today is a sunny day.
So when she writes, it almost look like writer's cramp, but her brachial or arm dystonia actually is caused by exposure to neuroleptics. Okay, so these are examples of tardive dystonia. It can affect the face, it can affect the trunk, it can also affect the limbs. So now the third major type of tardive syndrome is what we call tardive akathisia. So akathisia just means there's a subjective feeling of restlessness, and also objectively the patients just look restless. And sometimes you only see probably the objective part. They don't really have too much subjective restless feeling, but they do have a lot of subjective restless movements. And on the other hand, sometimes you hear more subjective complaint of restlessness, but you don't really see too much restless movements. But ideally, you want to see both the feeling, the subjective feeling, and also objective movements. And again, just based on phenomenology, it's hard to tell whether akathisia is caused by exposure to neuroleptics or is caused by something else. Like, for example, people with Parkinson's disease, they can have akathisia as the first symptoms of their Parkinson's disease. But in those patients with Parkinson's disease, the akathisia just sounds like and looks like tardive akathisia. So just by phenomenology, it's hard to tell what the etiology is. So tardive akathisia usually is generalized. So the patient just cannot sit still or stand still. They have to constantly pace around. And so this patient took Haldol and Geodon for bipolar disorder for years, and then later developed the tardive akathisia. So during the entire interview, she could not, stand still. So she had to constantly pace around.
So you were, you feel 3 times a day. Yeah, that's right. That was the record that we made. So you, and then we were supposed to see it again. Here.
So this is an example of tardive akathisia. So there's also acute akathisia as acute EPS. So again, just look like tardive akathisia. So based on phenomenology, there's no way you can tell whether this is tardive or this is acute EPS type of akathisia. So you really need no history. So again, most patients with tardive akathisia, they have generalized akathisia, but once in a while, we also see patients with more focal akathisia. But usually, the distribution, for a reason we don't know, usually is oral or is genital. And also, often they describe the feeling instead of restless as pain. So, so this patient took Zyprexa, I think probably about 10 years for bipolar disorder, and then later developed several types of movement disorders. So she has frequent blinking, so she has tardive blepharospasm. So she's most bothered by pain in her mouth.
Numbness in my tongue and pain in my tongue. Numbness in the roof of my mouth. And the bottom lip.
And she has a lot of workup, dental workup, to figure out why she had pain in her mouth.
I've been going on for over a year.
Now
Look up and ceiling.
So frequent blinking. There's a very mild tardive
Down
spasm.
in the floor. Okay. Look at camera. Okay. Show me your teeth. Okay, good. Now open your mouth.
So just very slight movement. So she also has tardive dyskinesia.
Okay, stick your tongue out.
Okay. So this patient has several types of tardive syndrome. So frequent blinking is tardive blepharospasm. It's classified as dystonia. She has mild tongue and mouth movements. That's what we call classic tardive dyskinesia. And she also described very, very severe, intense pain in her mouth, and that's what we call tardive akathisia, but in her case, more focal. And they respond differently to treatment, which I'm going to talk about later. So for diagnosis of tardive syndrome, most times it's very, very straightforward. You get a history of exposures to dopamine receptor blockers, and you see things that are consistent with tardive syndrome, and you exclude other etiologies, and you make a diagnosis. So it's a no-brainer. I mean, diagnosis is very straightforward. Only in very, very unusual cases that you have to think outside the box. And one example is what we call double dyskinesia. So the patient has underlying hyperkinetic movement disorder. For example, tics. And the patient has been treated with neuroleptics for tics. And then years later, the patient develops a different type of movement disorder. And then you're not sure where you're dealing with natural history of this disorder, a hyperkinetic movement disorder, because tics can change. Or you're dealing with a tardive syndrome. So, or you're dealing with a combination of both. So people refer to this kind of situation as double dyskinesia. And the other things that we have to keep in mind as a neurologist is kind of pseudo-tardive dyskinesia. So the movements look like tardive, but they're caused by other etiologies. So I'm going to show you some examples of either double dyskinesia or pseudo-tardive dyskinesia. So this patient is referred from Western State Hospital. So he has been there for over 15 years for the diagnosis of schizophrenia, and has been on Haldol, Seroquel, and more recently on Clozaril. And in recent years, he developed involuntary movements, and also he becomes sort of Parkinsonian. So it was sent to me at Harborview. So you see mouth movement. You also see forehead movements, which is a little bit unusual for tardive dyskinesia to involve forehead.
Don't move your head. Okay. I think that's tricky. You look to your right, just turn your eyes.
So whenever he tried to move his eye, he had to turn his head. So again, we don't see that in tardive dyskinesia.
Now look at camera. Okay, don't move your head, just move your eyes. Look at my nose here. Now look back at the camera. Okay, again, don't move your head, just move your eyes. Look out at the ceiling. Look up and see. Okay. Look at camera. Again, don't move your head, just move your eyes. Look up and ceiling.
So we see this kind of eye movement abnormalities in Huntington's disease. It's called oculomotor apraxia. Whenever they move their eyes, they have to move their head.
Look at the camera. Okay, now squeeze your eyes shut like this. Really hard, like they were soaked in.
So again,
Keep doing.
so he cannot maintain constant movements.
Like this. Really hard.
So he's unable to do so. So this is what we call motor impersistence. You see that in Korea, but not in tardive dyskinesia. So again, he has problem keeping his mouth open. So motor impersistence of mouth opening,
All the way out.
and also motor impersistence of tongue protrusion. So in this case, I was seeing enough sort of red flags So forehead movements, unusual for tardive dyskinesia. And he has oculomotor apraxia. He also has motor persistence. All these are hallmarks of Huntington disease. So I did genetic testing, came back positive. So his Huntington disease started with neuropsychiatric symptoms. So again, at this point, it's hard for me to tell whether his mouth movements are tardive or a part of his Huntington, yes, chorea, or the combination of both. So his mouth movements, could be, double dyskinesia, or just pseudo-tardive dyskinesia, or just tardive dyskinesia. But at this moment, I cannot tell. And we also see double dyskinesia in people, with tics, who are treated with neuroleptics, or with other movement disorder, which were treated with neuroleptics. Okay, so this lady was admitted to neurology service for altered mental status, and the next day on rounds, I saw the mouth movements that looked just like tardive.
Mở mắt ra nhìn ổng. Mày nhìn đây này. Thấy cái tay không? Đó, nhìn đó. Đó nhìn đấy. Ý mở mắt bự ra. Rồi.
Ask her to open her mouth wide open.
Mở miệng lớn lên. Mở bự ra. Mở miệng bự ra.
So again, very stereotyped, repetitive, and rhythmic movements.
Stick her tongue out.
Cái mở miệng lên để lưỡi ra.
Hold it out for a while.
Cái cầm đó.
Keep it up.
So you can see a little bit sort of pharyngeal, laryngeal movements, also very stereotyped. And now,
Ask her
after
to open her,
putting back
open her
the
eyes.
dentures,
Mở mắt lên đi.
the movement disappear.
Nó, chỉ mở mắt lên, nằm cái mở mắt lên.
And after dentures, is removed, the movements show up yet again. Okay, so this type of movements or dyskinesia is called adentures dyskinesia. So it's not tardive. It just it's caused by loss of proprioception. But again, just by phenomenology, they just look like tardive movements. So, but in this case, we cannot get a history of exposure to any neuroleptics or antiemetics. So I just call that this is pseudo-tardive dyskinesia. So again, just because the movement look like tardive doesn't mean it's tardive. You really have to get a history of exposure to medications. Okay, so now let's talk about treatment of tardive dyskinesia or tardive syndrome. The first question is whether we should continue neuroleptics or not. And before we can decide that, we have to know what's the chance that tardive syndrome will go away. It really depends on the types of tardive syndrome. And for classic tardive dyskinesia, about a third chance that the movement will go away, but less so with tardive dystonia or tardive akathisia. And the second question is, does continuing neuroleptics worsen tardive syndrome or not? And in terms of symptoms, no, because actually it masks the symptoms of tardive syndrome. But in terms of natural course, we don't really know. So it's still sort of up in the air whether continuing neuroleptics are going to worsen tardive syndrome in terms of natural course. For that, we don't know. And the third question is, does symptomatic treatment tardive syndrome change its natural course? And for that, we don't know either. We know that symptomatic treatment tardive syndrome have symptoms, of course, but we don't know whether it changed natural history or not. So for classic tardive dyskinesia, those repetitive mouth movement or body movements, and most of the time patients, they're not really physically bothered by the movements. Maybe psychosocially they are bothered by that. So a lot of time after explaining to the patients, and sometimes you can you can decide together that there's no need to treat that. If there's a need to treat classic tardive dyskinesia, is usually for psychosocial reason. And the treatment choice is dopamine depleters. And for reason I mentioned to you, these days I prefer using tetrabenazine. It's safer, and it was finally approved by FDA a year ago to treat movement disorders. And if there's contraindication for tetrabenazine, like if the patient still has active depression or very, very bad anxiety, and then sometimes I use GABAergic medications, or I use low dose atypical neuroleptics like Seroquel or Clozaril. And one thing that keep in mind is that it's very different from acute EPS. For acute EPS, they respond very well to anticholinergics. But for classic tardive dyskinesia, actually it can be worsened by anticholinergics. So a lot of time when I see patients with tardive dyskinesia, they're also on anticholinergics like cogentin. The first thing that I do is to stop cogentin to see how they're doing. So anticholinergics help acute EPS, but it can worsen classic tardive dyskinesia. Okay, so how about tardive akathisia? So the same as tardive dyskinesia, tardive akathisia does not respond to anticholinergics. Whether anticholinergics will worsen tardive akathisia or not, for that I'm not entirely sure. But I know for sure that anticholinergics do not help tardive akathisia. And dopamine depleters also help tardive akathisia. So these days I'm using amendedine, I think, more often for tardive akathisia if there is a contraindication for tetrabenazine. And sometimes narcotics also help tardive akathisia. But still, dopamine depleters are the most effective medication for tardive akathisia. How about tardive dystonia? This is harder to predict. Some patients with tardive dystonia respond better to anticholinergics, and some of them respond actually better to dopamine depleters. So that's why it's important to know what type of tardive syndrome you're dealing with. If just tardive akathisia or tardive dyskinesia, you should definitely avoid or should not consider anticholinergics. But if the predominant picture is tardive dystonia, and sometimes you can still try anticholinergics first. And of course, you can always use baclofen for dystonia, and for tardive dystonia affecting the eyes or the neck. Usually my first choice is Botox injection, just like other type of dystonia. In refractory cases of tardive dystonia, and these days people are doing GPI DBS to treat tardive dystonia surgically. Okay, so we met her earlier, so she has a combination tardive dyskinesia, tardive blepharospasm, and also tardive akathisia that is focal. So I started tetrabenazine.
So what is happening when you started taking
The pain in my mouth is a lot better. A lot better. Things like my tongue isn't moving as much. The blinking is, I can maybe a little better.
Okay, that is still pretty frequent.
Yeah.
So her tardive akathisia, the focal pain, went away almost completely. Tardive dyskinesia also better. But her tardive blepharospasm didn't improve with tetrabenazine. So I started Botox injection. Now it's under control, the tardive blepharospasm. So it just show that different types of tardive syndrome respond differently to treatment. Okay, so in terms of mechanism, that's probably everybody's guess, and the theory is there's a denervation hypersensitivity. But in this case, the denervation is chemical denervation by blockage of the receptors. In terms of pathology, genetics, animal models, or functional imaging, we don't really have too much evidence or too much concrete findings. So it's still basically the clinical diagnosis. Okay, so I will conclude today's talk with this slide. So always think twice before starting dopamine receptor blockers, and if it's possible, use safer ones. I know it's going to be very difficult, I think, for psychiatrists, because a lot of times you just You just have to bite the bullet, use neuroleptics. And the diagnosis of Tardive syndrome is usually very straightforward, but in questionable cases, keep the possibility of double or pseudo Tardive, dyskinesia in mind. And as I mentioned earlier, you should tailor the treatment to a type of Tardive syndrome, depending on whether it's Tardive dyskinesia, Tardive akathisia, or Tardive dystonia. And the last thing that's probably the most important, always communicate with the physician who started the neuroleptics or dopamine receptor blockers. And there are several reasons for doing that. The first, you try to avoid any possible medical legal consequences. So now there are several sort of litigations against the use of Raglan or other neuroleptics. Also, the question of whether it's safe to stop neuroleptics or not. I'm a neurologist, so I don't make that decision. I always communicate with the psychiatrist to see whether it's safe to discontinue neuroleptics or not. But if neuroleptics or dopamine receptor blockers were prescribed for other reasons, like for nausea, vomiting, for headache, and for insomnia. And in those cases, I feel comfortable to make a decision myself about stopping neuroleptics. But if a neuroleptic is started for psychiatric reasons, usually I have to rely on psychiatrist's judgment to decide whether it's safe or not to discontinue that. So this is the end of my talk, and I'm happy to take questions. Okay.
Dose reduction help at all?
Huh?
Dose reduction?
Depends on the type. Yeah, I would say probably for Tardive dyskinesia, I think probably it's still somewhat, even it's idiosyncratic, it's still dose dependent, but not so much for Tardive dystonia or Tardive akathisia. And the other thing is that actually, when you increase the dosage, a lot of times the movements will get better, but temporarily. But in the long term, they will come back to bite you.
You mentioned about the one individual that had haloperidol for a couple of weeks after surgery and then got blood flow spasm. How early can people get tardive dystonia, dyskinesia symptoms after using neuroleptic?
Yeah, I think before people thought the cutoff was 3 months, but now it's shortened to 1 month. And there are case reports, probably not so many, but there are few case reports that people can get Tardive syndrome, like just after several days. But in those case reports, it's hard to tell whether they had some sort of cryptic exposure in the past. So I think in general, we still think probably you need at least 1 month's exposure to dopamine receptor blockers to develop Tardive syndrome. But again, there are case reports with exposure shorter than that. And for that patient, I think he got that probably for about 3 to 4 weeks. That's why we feel comfortable to call his blepharospasm Tardive blepharospasm.
If someone develops like that patient did sometimes after a relatively short period, is there a higher than 33% chance that they're going to recover spontaneously, or is it just the same as if they've been on something for years?
I'm not entirely sure whether the duration of exposure determines the chance of spontaneous remission. Yeah, I have to look it up. Yeah, the other thing is about age. For idiopathic dystonia, usually follows certain patterns, and usually we see idiopathic blepharospasm in people much older, usually in their 60s or 70s. So if you see blepharospasm at age younger than that, usually it's secondary. Any other questions?
Can you clarify? You seem to say that if a person stays on neuroleptic, they won't necessarily have their tardive dyskinesia get worse over time.
We don't know.
You don't know?
Yeah, we don't know. Yeah, we know that if you increase the dosage, the symptoms will get better. But whether continuing neuroleptics is going to perpetuate the natural course of Tardive syndrome, I think most people probably will think yes. But the problem is we don't have evidence for that. It's hard, as you can imagine. It's almost impossible to do a clinical trials, like this. So I think probably by common sense, we'll tend to think, yes, continuing neuroleptics probably is going to perpetuate Tardive syndrome. But in reality, no, yeah, we don't know.
The old figures were 5% per year cumulative for the atypicals in terms of getting tardive dyskinesia. Do you believe that figure?
I think that's prevalence data. I'm not sure about the incidence, no, yet per year.
It kind of adds up.
Yeah.
Somebody's had 30 years, they have...
I would say probably the annual incidence probably is much lower than 5 to 20%. Mm-hmm. Yeah, let me just pull out that. Yeah, I think you're probably asking sort of the binding affinities, issues here. So if you look at the number for risperidone, actually the binding affinity, unfortunately, is higher than Haldol. So I don't really believe risperidone is an atypical neuroleptic. I think it's as typical as Haldol in terms of the risk of Tardive syndrome.
What's the actual incidence? I think he's asking.
Oh, the incidence? Yeah, I'm not sure if people have look into that. And the other thing is it's also dosage dependent. And I don't really know the true incidence of Tardive syndrome caused by risperidone. But just in terms of number, binding, and affinity, it's not going to suppress me if the incidence is very, very high. Okay. So, okay, yeah, thanks for paying attention. Yeah.